Imaging case presentation of mastoiditis in plain X-ray. This case presented with mastoid view for report. Maybe found it's easy to diagnose glioma, to diagnose cervical disc herniation, and it's difficult to diagnose plain X-ray of mastoiditis. We are not familiar, we are not interested by this. We look for it as it is a small subject, imaging of mastoiditis. Here we see mastoid bone, and in another view, left and right, mastoid bone and this cavities, this mastoid air cells, and ask yourself, there is evidence of mastoiditis or any abnormalities, and you talk next and explain how to diagnose this. This is mastoiditis, right and left, mastoiditis imaging. What we see: pneumatization recons of the temporal bone in anatomy. 5. Middle ear squamomastoid, and this is our interesting squamomastoid, and the others pili-labyrinthines, petrous apex accessory cells. We talk about mastoid in this subject. Types of mastoid aerations may be cellular, like this. We see multiple cells. Diploic, and this is not pathology. Acellular or sclerotic aerations, and this is in pathologies and other mastoiditis. Pneumatization of mastoid region will be divided into sclerotic, pneumatization absent; diploic, pneumatization partial; pneumatic mastoid, pneumatization complete. The non-pneumatized areas are the bone marrow in the diploic mastoid, like this, and the dense bone in the sclerotic mastoid. So, non-pneumatized areas may be a diploic bone marrow and diploic mastoid physiological, or sclerotic dense bone in mastoiditis. This is squamomastoid type anatomy, non-pneumatized part of petrous. High resolution image showing pneumatization of temporal bone, tip of pneumatized cells normally. This is view of mastoid, how to do it in X-ray, plain radiograph. Low view, transverse view, transorbital view, Townes view. What we look anatomy in plain radiograph, lateral film for mastoid. Look for temporomandibular joint, external auditory canal, dural plate, sinus plate. This is mastoid air cells. This is clavus 27. This is normal mastoid air cells lateral view. Normal mastoid, keep this in your mind. Normal mastoid air cell shape in normal X-ray must be well defined, no haziness, no darkening, no blaring, no sclerosis, no density. 5. No. Well defined, no haziness, darkening, blaring, sclerosis, density. This is normal mastoid air cells. Normal mastoid air cells, well pneumatized, well defined air cells, no haziness, no darkening, no blaring, no sclerosis, no density, no cavity. Section below, external auditory canal, as we see, and this mastoid tip cells. This mastoid tip cells, and this is occipitomastoid sutures. This normal mastoid in high resolution CT. Here is zygomatic accessory cells, jugular spine, carotid artery canal. zygomatic accessory air cells. This is zygomatic accessory air cells. At the level of internal acoustic canal, we found mastoid antrum and lateral semicircular canal. So this is mastoid bone high resolution CT, mastoid air cells. Mastoid air cells, and this is view high resolution petrous bone. This is mastoid air cells. Number 9. 5-factor arranging middle air pressures. There's always association sometimes between mastoiditis and otitis media, serous or secretory. 5 factors: arranging middle air pressures, ventilation from Eustachian tube, passing of gases into a circulation by diffusion, thickness of middle ear mucosa, elasticity of tympanic brain, size of mastoid pneumatization. This is our lectures without which you interest. Size of mastoid pneumatizations determined 1 factors of middle air pressure. What is the rule of X-ray in mastoiditis? What we look for X-ray in mastoiditis? X-ray of mastoid in the affected side showed coalescence, sclerosis, presence of an abscess cavity or fluid, purulent fusion of wall, clouding of air cells, darkening of cells, significant loss in intensity of shadow of the wall of the cells, bone destruction as in acute subperitoneal otitis media. 1. Firstly, coalescence of air cells. 2nd, sclerosis of air cells. 3rd, presence of abscess cavity fluid. 4th, clouding of air cells. 5th, darkening of air cells. 6th, significant loss in the intensity of shadow of the wall of the cells. 7th, lastly, bone destruction in acute subperitoneal otitis media with cavity formation. Lack of sensitivity to differentiate stages of the disease failed to show petrous apex in any great detail. This is role of X-ray in mastoiditis. X-ray in mastoiditis, we see bone destructive change in initial phase of mastoiditis. Trabecular bone because of the remaining cells. Exudative form of mastoiditis characterized by darkening of cells. We talk about darkening of cells because of exudative. Significant loss intensity of shadow fall of the cell. Sometimes almost a complete absence of image, which explained by more resorption process. Purulent fusion wall of the cell with formation of an abscess cavity of purulent fluid in the mastoid process determined. This radiograph of temporal bone, acute mastoiditis. Look, cells dark, large, destructive hairs in the mastoid bone, secondary symptoms of enlightenment. As we see, this is acute mastoiditis, cells dark and large, bleared, haziness, darkening, loss of will definitions, even destructive process present in the hairs of mastoid bone. This acute mastoiditis, huge bone defect in the mastoid process, supraosteal abscess, right temporal bone, left temporal bone normal. Comparative study. This is normal and this is right of acute mastoiditis, darkening, haziness, loss of well definitions, blearing, even destructions, area cavity formation or supraosteal abscess. What to differentiate for cavity in the mastoid? Either cholesteatoma, secondary large antrum normally, post-operative cavity, eosinophilic granuloma, TB, mastoiditis. What is differentiation between operating cavity or the cavity from cholesteatoma? Differentiation depends on margins, appearance, sclerosis. Operating cavity, margins irregular due to osteogenesis, and cholesteatoma smooth. Appearance, operating cavity homogeneous, in cholesteatoma cotton wool appearance. Operating cavity site is middle ear mastoid, cholesteatoma only involve mastoid area. Sclerosis, operating cavity absent, present in cholesteatoma. This is Histiocytosis is xerophilic granuloma area of right temporal bone with cavity formation starting. This is X-ray normal temporal bone, large solitary cell in top of the mastoid process with a thin line of shadow path. Here cavity of cholesteatoma. Cavity of cholesteatoma in top of ridge with a thin line of shadow contour. Cells are missing as we see. Large cavity supraosteal abscess. Acute mastoiditis formed of several cells as we see. Large apical mastoiditis, absence of pezol, cell abruptly darkened on top of mastoid compact bone, visible cells elite inner and outer cortical plate seen, visible defect internal auditory canal, plate top, outer cortical plate, cortical thickness here. Large abscess cavity, large acute mastoiditis formed of several cells as we see. Large abscess cavity. Left apical mastoiditis here, left apical mastoiditis. This, as we see, acute mastoiditis. Acute mastoiditis, bone pneumatic type. Beginning of these, the cells of temporal bone dark in the top ridge, visible destructive process as we see, and later on full recovery, lightness of cell of temporal bone, reparative bone changes the former site of lesion. This is acute mastoiditis. This here CT high resolution show right macrotia and the agenesis of the ear, showing limited amount of bone in the right ear. What CT scanning role of mastoiditis? Soft tissue density instead of air in the mastoid air cells, suggestive of mastoiditis. Soft tissue density replace mastoid air cells. Opacification of mastoid air cells, loss of sharpness or visibility of mastoid air cells, haziness or distortion of mastoid outline, enhancement of area of abscess formation, elevation of periosteum of mastoid process, or posterior cranial fossa, osteoplastic activity in chronic mastoiditis, which leads to sclerosis. CT acute mastoiditis, as we see, cavity formations, destruction of bone, loss of well definition, haziness, acute mastoiditis. CT acute mastoiditis. This is abscess formations, this is destruction of bone, darkening, haziness, and the enhancement of the wall in acute mastoiditis, mastoid abscess. Imaging of complication of acute mastoiditis in children. Classify mastoiditis as incipient or coalescent due to detect intracranial complications. Complication of acute mastoiditis, as we see, supraosteal abscess, epidural abscess, subdural empyema, brain abscess, meningitis, lateral sinus thrombosis, carotid artery involvement, acubical petrositis. Acute incipient mastoiditis, 3-year-old girl, suspected right acute mastoiditis. As we see in axial temporal bone, increased attenuation of entire right middle ear, no osseous defect. CT normal aeration of tympanium and the mastoid in the left side. Incipient mastoiditis. Acute incipient mastoiditis, enhanced CT show no complications. Acute coalescent mastoiditis with supraosteal abscess, 2-year-old girl, acute right mastoiditis, otomastoiditis, show temporal bone, abnormal soft tissue attenuation, right mastoid air cells with erosion of external cortex and the sigmoid plate. Abnormal attenuation seen in the left side, or probably due to serous otitis. Acute coalescent mastoiditis, وسبريوستيال abscess no intracranial complication. Perisinus abscess as we see ولeft acute mastoiditis. Perisinus abscess as we see axial CT scan show increased attenuation left mastoid air cells with subtle erosion of the mastoid cortex. Ipsilateral sigmoid sinus same side show unsuspected epidural abscess. Petrous epicytis in 7-year-old girl with fever, right side facial bone diplopia. We see temporal bone increased attenuation of mastoid air cells and the aeration of right petrous apex. Aeration right petrous apex. This is petrous epicytis. Epidural abscess. This is one complication of acute mastoiditis. Epidural abscess, as we see, epidural abscess, enhancement of the wall, epidural abscess. Dural venous thrombophlebitis, left side mastoiditis with dural venous thrombophlebitis, this left-sided mastoiditis. Subdural empyema, 3-year-old girl with left acute mastoiditis, subdural empyema. Carotid artery involvement also in acute mastoiditis. Acute mastoiditis, radiographic evaluation, diffuse rarefaction of bone and breakdown of cellular space, don't forget. Infectious causes of torticollis mastoiditis, episoid abscess, one causes of torticollis. This is unenhanced and enhanced axial CT with acute torticollis, right ear pain, coalescing mastoiditis, eroding medial surface of mastoid, inferior to this abscess involving right sternocleidomastoid, episoid abscess. Episoid abscess, rare complication of suboperative mastoiditis when infection erodes the mastoid tip into neck, forming an abscess. Mucosal spasm if sclerocytomastoid result in torticollis abscess spread down to sternocleidomastoid into lower neck associated with cholesteatoma sometimes.